Hello everybody, I'm Dr. Deeksha Pandey and you are watching Urogynecology for Beginners. I'm a little more excited today as today is special. I'm going to upload the 200th video in this very channel. The journey, which started very small, in 2 years' time, it has crossed 16,000 subscribers, and today, while celebrating this occasion, which is so very important for me, I want to thank each one of you from the bottom of my heart for subscribing, sharing, and liking our videos. So when we are at this milestone, the video today has to be something very special. And as per the suggestion of my fellows, I'm going to upload today one lecture which according to them is my best lecture ever, and the lecture is on physiology of pelvic floor. I feel if you want to become a urogynecologist, if you are starting your journey, there are 3 aspects of urogynecology which you must understand. The first one is anatomy, which will teach you all the tips, tricks, basics of surgical techniques, and you have to do surgery if you are planning to become a urogynecologist. Second area is physiology of pelvic floor, which will make you understand how actually these organs are being controlled and how they're working, and at what level things go wrong when diseases occur, so that if a patient presents with a particular symptom, you can pick it up at what level the defect has happened or things have gone wrong. The third thing is the pharmacological basis of pelvic floor medicine. That means if we can understand all the neurotransmitters, all the nervous stimuli, all the receptors which are active and work in these very organs which are related to pelvic floor, we can understand, or it becomes very easy for us to prescribe a particular medicine to a patient, and we know why we are giving what we are giving to our patient, which makes a lot much more sense when we do it without understanding it. So already, if you have not seen the surgical hacks and anatomy video, I would request you to go back and see that. Today I'm going to teach you about the pelvic floor physiology, the basis of pelvic floor medicine. And sometime later in future, I'm going to upload another video which will be on pharmacology of pelvic floor. So today, let's understand how the pelvic floor works and who controls it. Pelvic floor physiology is actually a beautiful symphony between the muscles and the nerves. As you all know that pelvic floor is the board or a platform which is holding important structures in the pelvis like bladder and urethra, bowel, that means rectum and anal canal, and also uterus and the vagina. So its physiology is centered on bladder and bowel control, sexual functioning, and also pregnancy and childbirth. First, the most important question is, as a clinician, why do we need to learn the physiology? The most important reason is where we do not find a structural defect in the pelvic tissues, we need to understand what's actually going wrong at the level of physiology so that we can make a perfect diagnosis for our patient. When we will be able to do that, then only we can refer our patient to the correct department. For example, neurology or physiotherapy, or maybe if it is diabetic problem, diabetic neuropathy or musculopathy, we can send her to endocrinologist for the control of diabetes. It is also important for rehabilitation purpose because if muscles and nerves are not working, we can take the help of physiotherapist for nervous stimulation, or to activate the accessory muscles which will help her to regain the functionality back. And last but not the least important is how do we decide which drugs we want to give? That we can do only if we can understand the physiology perfectly. However, this pharmacotherapy, as I promised, I will be taking in another lecture. Today, we are not going to discuss much of pharmacotherapy in this lecture. Before delving into the physiological details of pelvic floor, I just want you to quickly revisit its anatomy. And here comes the rule of three. So, our pelvic floor is holding three important organs or structures for us. Anterior to posteriorly, it is bladder with urethra, uterus and vagina, and rectum with its anal canal. There are three groups of muscles in the pelvic floor. I'm not going to the details as I have discussed this topic in detail in the anatomy lecture. I hope you remember it. The topmost layer is pelvic diaphragm, then comes the deep pouch and muscles in it, and the third one is the superficial pouch with its three groups of muscles in it. Bony relations, again it has three. So the important pelvic girdle, which is the bony pelvis, this bony pelvis is in relation with hip bones on both the sides, and in the midline, if we go cranially, there is the vertebral column or the spine. There are three important nerves, or only three groups of nerves, which are handling the pelvic floor: somatic nerves, sympathetic, and parasympathetic nerves. I want you to keep these important points in your mind before we start enjoying the symphony of muscles and nerves in the pelvic floor. Talking about the pelvic floor, it provides support or acts as a floor for the entire abdominal viscera. And the main action of this pelvic floor is to constrict and give continent mechanism to bladder, bowel, and to certain extent vagina also. One important thing you must remember here is, as you saw, the muscles have contractile power here, but they need nerves to tell them to do so. What you saw here is how the skeletal muscles of pelvic floor work together. However, you must understand that these are not the only muscles which are required for an adequate or proper functioning. We need visceral muscles too. And visceral muscles are the muscles which are situated in the viscera like bladder, bowel, uterus, vagina, urethra, and anal canal. These viscera have their own muscles which work in again a well coordinated manner. They have the contractile power. However, they also need a boss to tell them how to work, when to work, and that boss is known as the autonomic nervous system. If you look at the neuromuscular functioning of pelvic floor, it is just like a very well coordinated company setting. You know well how a company works. There is a boss or a CEO who decides and gives orders. These orders are ultimately followed by the employees to yield the ultimate output. Likewise, in our body, the brain is that boss. It will give orders to different organs in different situations. Now, how these orders are communicated from the boss to the worker is important to understand. Number one, the old fashioned way. A peon takes the orders in a file and gives it to the employee. That's how the direct coordination happens from the brain and spinal cord to the skeletal muscles. They have direct nerve communication. Second way is the new way, which is through messages like WhatsApp these days. So the orders can also be communicated through indirect messages via internet or some app. The same thing happens in the autonomic nervous system with the help of ganglion, parasympathetic and sympathetic. The third kind of functioning is when it becomes a reflex. In day-to-day routine activities, why the CEO or the boss should be involved? They just become the routine or reflexes, which can be handled without the active involvement of higher centers. We need to simplify our concepts because, as you can see in this diagram, pelvis is a complex network of nerves. To simplify it, there are basically two groups of nerves. One, which are supplying the skeletal muscles, are called somatic nerves, and the ones which supply the visceral muscles are called the autonomic nerves. Autonomic nerves can further be divided, as you all know, into sympathetic nerves and parasympathetic nerves. But if you just see what the system is doing, is very simple. They are receiving the signal from somewhere, and then depending on what signal they have got, they are sending a reflex action to that. So the system is simple. There is an input, and to that there is a reaction or an output. Now, specifically to pelvis, I will just introduce you the names of these nerves. First is the somatic nerve. Somatic means sensory and motor nerves for skeletal muscles. So remember, two important plexuses are there, only two important plexuses, which I will tell in detail about: sacral plexus and coccygeal plexus. Parasympathetic nerve, which again has sensory and motor, is known as pelvic splanchnic nerve. And how do you remember this? Parasympathetic nerve means PSN. Pelvic splanchnic nerve, short form again PSN. The third kind of nerve is the sympathetic nerve or sympathetic supply, and that comes from the pelvic part or sympathetic chain. Forget about the pelvis and urogynecology for a moment. Let's revise the basics. So this is how somatic system works. So from the skeletal muscles, the sensory information travels through the dorsal root to spinal cord, and the response to it comes out from the ventral root as a motor reaction. Now don't get confused in roots and rami. Roots of a tree means that part which is hidden inside the soil. So the roots, the dorsal and ventral, are also hidden inside the bony vertebral column here. What's coming out of the vertebral column are the rami. Now remember, while the roots are either sensory or motor, the rami that are coming out are mixed. That means they will have mixed fibers of sensory as well as motor. Having understood the basics of somatic innervation, let's come back to the pelvic floor. The main somatic supply of pelvis is through two nerve plexuses, the sacral plexus and coccygeal plexus. It's easy to remember, as the continuation of vertebral column in the pelvis are only two bones, sacrum and the coccyx. So two plexuses, sacral, the upper and the bigger one, and coccygeal, the lower and smaller one. The first, sacral plexus, is formed by the ventral rami of lumbar 4, 5, S1, S2, S3 and 4. Now what is the easy way to remember it? Sacral plexus is lumbar 4 to sacral 4. These 6 rami from lumbar 4 to sacral 4 join together to form a flat band which lies above the piriformis muscle covered in its fascia. External iliac blood vessels, the artery and the vein, lie above this plexus. After giving various branches to the structures in and around, this sacral plexus terminates into two terminal branches, the sciatic nerve and the pudendal nerve. This sacral plexus has 8 important structures to supply. The first one is simple to remember, as the entire plexus runs over the piriformis muscle. It has to give a tax to that, so it has to supply the piriformis muscle. Second thing I want you to remember is the pelvic diaphragm. Here we are talking about pelvic diaphragm, and sacral plexus has to supply it because we are actually studying the nerve supply of the same. So pelvic diaphragm means levator ani and coccygeus muscle. It also supplies one more organ which is important to us, that is external anal sphincter, and supplies also the perineum, entire perineum including the superficial and the deep pouches. Two muscles I want you to remember: it supplies obturator internus and gluteus muscle. And this thing in yellow, which might be a little tricky for you to understand here, but it will help you later to understand when we talk about autonomic nervous system, that sacral plexus also gives nerve fibers or preganglionic fibers to the parasympathetic nervous system, that is pelvic splanchnic nerve. So I'll just repeat it. The 8 structures which are supplied by various branches of sacral plexus are: number 1, the piriformis muscle; 2 other muscles, obturator internus and gluteus muscle; pelvic diaphragm, obviously, external anal sphincter and perineum; and it also gives preganglionic fibers to pelvic splanchnic nerve, which is actually the parasympathetic supply of pelvic floor. The other plexus is the coccygeal plexus. As is the bone, this is a smaller plexus and easier to remember. The formation of this plexus takes place from ventral rami of S4, S5, and also the coccygeal nerve. Now, one thing you might have noticed here, that S4 actually is common for both the sacral and the coccygeal plexus because of its location. Site of this coccygeal plexus is coccygeal muscles. It runs in front of the coccygeal muscle, and I hope you remember, where is the coccygeal muscle? Coccygeal muscle is at the upper border of levator plate or levator ani muscle. And if you remember it properly, this is actually sacrospinous ligament, which we use so very often for vault suspension, is the fibromuscular thickening of the same coccygeus muscle. So the interpretation or application of this knowledge here is that whenever you are doing a sacrospinous ligament fixation, try to go to the sacrospinous thickened part of the muscle and don't do it with the coccygeus, because then you have more risk of coccygeal hitch. When we do, there is more risk of injury to the nerves of coccygeal plexus. And what does this plexus supply? It supplies the coccygeus because it has to give the tax to it, and also the pelvic diaphragm. I told you that's why we are studying it today. And it also supplies, the coccygeal plexus also supplies the skin at the coccyx. So small area of distribution, small formation. This is the smaller coccygeal plexus. So these two plexuses, the sacral plexus and coccygeal plexus, basically are the somatic nerve supply for the pelvic floor and the organs in it, and they supply mainly the skeletal muscles. The other nervous system which is involved in the normal and abnormal functioning of these organs and the pelvic floor is the autonomic nervous system. Autonomic nervous system. You know, it controls the visceral muscle. That means the muscle within the bladder urethra, within uterus and vagina, and also in the walls of rectum and anal canal, as far as pelvis is concerned. The basic meaning of autonomic is self-governing. So it gives the control to our internal environment. And this autonomic process never sleeps or never stops. Consciousness and memory are frequently considered the most important functions of the human nervous system, but actually, it is the visceral control, the autonomic nervous system, that makes it all possible. Now, there are two divisions of this autonomic nervous system. One is the sympathetic system, other one is called the parasympathetic. They act independently of each other. But it's not that as we usually think that they are different situations when sympathetic or parasympathetic will work. However, you must understand that for a normal person, for a normal situation in general, they work synergistically to control visceral activity, though they often work in opposite way. They are exactly like accelerator and brake of the car. Like both have to work in synchrony, though they work in opposite way for normal functioning of a human body. The main difference, if we compare the autonomic nervous system from the skeletal or somatic system, is one extra ganglion. We call it the peripheral ganglion. So as in somatic nerve, there is one nerve fiber and one nerve body. Here there are two nerve fibers and two nerve bodies. In between is the ganglion. So the nerve fiber that is traveling from central nervous system to this ganglion is called the preganglionic neuron, while the one which travels from this peripheral ganglion to the target cell is called the postganglionic neuron. So remember, somatic nervous system, one nerve, single messenger. However, in autonomic system, there is one extra ganglion which has to be crossed before the signal reaches the target cell. With their inherent similarities also, the sympathetic and the parasympathetic system have three anatomical differences. First is that the peripheral ganglion is arranged in a chain in sympathetic nervous system, and the chain is thoracolumbar. While in parasympathetic system, the ganglions are not in the form of a chain. However, the control, the preganglionic nerve is craniosacral. Either it comes from the sacral plexus or the cranium. Cranium means mainly the vagus nerve. So, sympathetic system is thoracolumbar with the help of a ganglionic chain, while parasympathetic system is craniosacral, wherein the nerve fibers from cranium is mostly vagus and sacrum is sacral nerve fibers, come and supply the organs. Now, I told you just a minute ago that there has to be an intervening ganglion. So that intervening ganglion in sympathetic nervous system is in the form of a chain very close to spinal cord. While, listen to me carefully, the ganglion of parasympathetic chain or parasympathetic system lies either in the organ itself, in the wall of the viscera, or very close to it. That means the preganglionic fiber of the sympathetic chain will be short, while those of the parasympathetic chain will obviously be longer. So what are the names of that sympathetic nerves and the parasympathetic nerves which are supplying the pelvic floor and the related organs? The sympathetic nerve is known as hypogastric nerve, while the parasympathetic nerve is known as pelvic splanchnic nerve. Now, the easy way to remember is parasympathetic nervous system is PSN, the mnemonic for it. And similarly, the pelvic splanchnic nerve also, if you shorten, it becomes PSN. So PSN, parasympathetic nerve, is pelvic splanchnic nerve, while the hypogastric nerve, you will remember, it is a sympathetic nerve. If you look at the actual anatomy of nerves in the pelvic floor and pelvis, it is a difficult or complicated network of various nerve fibers. For the sake of ease of understanding, on the left side, I have diagrammatically presented it to you. So imagine the aorta. Aorta bifurcates into common iliac arteries. So here at the junction where the bifurcation of aorta occurs, there is a plexus. Plexus does not mean a ganglion. Plexus means a mesh or a network of sympathetic fibers which are arising from the lumbar segment, to be exact, lower lumbar segment of the sympathetic chain, because I hope you remember that the sympathetic chain is only thoracolumbar. So lower lumbars are coming in front of the aortic bifurcation and making a complicated plexus here, and this plexus is known as superior hypogastric plexus. This plexus is entirely sympathetic fibers. Now this plexus gives two kinds of nerves, one on the left side, one on the right side, which are again sympathetic nerves. They are known as left hypogastric nerve and right hypogastric nerve. Now these hypogastric nerve again mix and match with the parasympathetic system, and the parasympathetic system is pelvic splanchnic nerve, and this pelvic splanchnic nerve is getting its fiber from, do you remember, from the sacral plexus. I have told you in the beginning to remember. I hope you have not forgotten. So some fibers from the sacral somatic nervous system are given to the parasympathetic system to form pelvic splanchnic nerve, which merges here with the hypogastric nerves right and left, and then these two together will form inferior hypogastric plexus. Having understood the basics of neuromuscular control, it's time to dive into the real world scenario. Let's start with the micturition reflex. So, this is the bladder with its two sphincters, internal as well as external sphincter. The control of bladder and internal sphincter is by sympathetic, that is the hypogastric nerve. The supply is to both the detrusor as well as internal sphincter, and what kind of action it is? You know, it's holding action. Sympathetic system, I always say, if it has sympathy on you, then only you will remain continent. Simultaneously, with the sympathetic, parasympathetic nervous system also, which is operated by PSN, that is pelvic splanchnic nerve, gives parasympathetic supply to the same detrusor and internal sphincter. But its action is to empty the bladder. That means contraction of the detrusor and relaxation of internal sphincter. The third nerve that is involved in micturition is the somatic nerve or the pudendal nerve. That's a branch, I hope you remember, of sacral plexus. Pelvic floor is voluntary. So this muscle is not under the control of autonomic nervous system. Rather than with our wish, we can contract and relax it with the help of pudendal nerve. Now what happens? As the drops of urine start filling the bladder, stretch receptors get activated. These stretch receptors are basically the parasympathetic ganglion in the bladder wall. When they stretch, they send signals to the spinal cord, which first acts through the parasympathetic nervous system with the help of, pelvic splanchnic nerve to contract the detrusor muscle and relax the sphincter as a reaction to this stretch. It is a self-generated reflex. However, seeing this activity, sympathetic system gets up and comes into action. And what does it do? It relaxes the muscle and keeps the sphincter in contracted state. This action reaction keeps on happening for a while till fatigue sets in and the lady feels an urgent desire to empty the bladder. Then at that moment, another reflex sets in that activates the pudendal nerve. which inhibits the external sphincter, that means releases it from its inhibitory control and lets the lady void. But even this is not enough. The boss, he is sitting at the top, at the level of pons, and he is called the Pontine Micturition Center, PMC. By default, PMC tries to trigger the voiding reflex. But there is one more control to the story, and that is the cortical center, or we call them suprapontine center in the brain. They have the ultimate power to control the entire system. And by default, they are inhibitory. So, whenever our suprapontine region or the cortex of the brain receive that this is an adequate place, an adequate time to void, then only the inhibitory control over the pontine micturition center is taken off and the entire cascade of voiding starts. Now let's see how all this understanding helps us understand the diseases of lower urinary tract. Situation number 1. If sensory nerve or ganglia in the bladder are damaged, no stretch response and no reaction by the parasympathetic system. Result would be an atonic bladder, which will lead to overfilling of bladder and overflow. It's called the overflow incontinence. Situation 2. If the spinal cord gets a lesion or an injury above the level of sacrum, it will disconnect the bladder to the sympathetic supply, which comes from the thoracolumbar sympathetic chain. So, what will it lead to? It will lead to spastic overactive bladder, which is now under the sole control of parasympathetics. Situation number 3. If the lesion is above the level of pons, the inhibitory social control would go away and the bladder will become automatic. That means it will fill and empty on its own anywhere and everywhere. I hope it is simple for you now to understand once you have understood the basics of physiology well, isn't it? I realize that it is too much information for one class, but I want to finish this topic today. So let me quickly tell you about the defecation reflex, which is exactly the way the micturition reflex works. Like urinary bladder, the rectum and anal canal also has two sphincters, the internal sphincter and the external sphincter. The nerve supply also is exactly the same way. Hypogastric plexus and hypogastric nerves, which are the sympathetic nerve supply, and pelvic splanchnic nerve, which is the parasympathetic supply, which contracts the rectal muscles and helps in emptying. The pudendal nerve supplies the external sphincter, which gives the voluntary control to the anal canal. Defecatory dysfunction can present as constipation, which, if not anatomically explainable, may be because of the uninhibited sympathetic response. Dyssynergia occurs when the rectum contracts but the sphincters fail to relax at that very moment. It is because the nerves are not able to talk to each other properly. Passive incontinence, where there is no urge. Internal anal sphincter, which is under autonomic control, has gone wrong. While in urge incontinence, which means that patient has a desire, a strong desire or urge to go to the washroom, but she can't hold it. It's because of the defect at the level of external anal sphincter, which is under the influence of pudendal nerve, branch of the sacral somatic plexus. Fecal seepage is when the patient doesn't realize and leaks. This happens when the sensory nerves or the visceral ganglia of the rectum or the anal canal had got injured. Last one is the functional fecal incontinence, which is very similar to urinary overflow incontinence, wherein the sensation again or the parasympathetic control has gone wrong, which presents as incontinence. I hope it was not too much of information in one lecture for you, but I really want to put all this together so that even if you want, you can check it out whenever you get time in bits and parts. But this information needed to be in one place somewhere. That was the idea. So let me make this easy for you by summarizing the most important points which I discussed. So, pelvic floor is not just a floor or a shelf. Its physiology is very important and is centered on bladder and bowel control, sexual functioning, and pregnancy. Physiology basically is a symphony between muscles and nerves, and a beautiful one. Muscles have contractile power, but they need nerves to tell them to do so. Based on these muscles, the nerves can be skeletal or the somatic nerves for skeletal muscles and autonomic nerves for the visceral muscles. Autonomic nerves are further divided into parasympathetic and sympathetic. In cases where there is no anatomical defect, we must think what level physiology has gone wrong. And this information, that's why we are studying this information in so much in detail so that we can manage our patients better and if required, refer them to the correct department. And with this, I wish all your incontinence patients a very dry Holi. Let the pelvic floor of all your patients find its zen very soon under your care. Thank you.